Okay, so we'll be continuing reviewing this family medicine CMS form 2, and we've done very few questions of it actually because it takes quite a bit of time to explain family medicine concepts, which are not clearly explained in the CMS form explanations themselves. So that's what this lecture is all about, to explain CMS form 2 in terms of what is high yield and what you should be concentrating on. So let's move forward. So we left off till question 6, and question 6 is that we left off till question 5, and now we're going to start from question 6. So physical examination is unremarkable and chest X-ray shows no abnormalities. It's normal. A 19-year-old college student with no past medical or family history presents with a 3-month history of cough occurring primarily in the mid-afternoon and evening. The cough is mild and not associated with other symptoms, slightly worsens in cold weather, and does not disturb sleep or limit daily activities. She has never been hospitalized. And these are your options. So I'll give you a minute to choose what you think. And this is a simple but important concept. So the correct answer is asthma. And the reason being is because cough variant asthma, it's it's a variant of asthma in which cough is the predominant symptom, such as chronic dry cough without wheezing, often triggered by cold air or worse in the evening night due to circadian bronchoconstriction. And physical exam and imaging are typically normal, but the diagnosis is confirmed with spirometry showing reversible airflow obstruction or methicillin challenge. So these both we've discussed in the previous videos, but it's important to identify when it's important to identify the symptom of cough variant asthma. It's important to identify the case when it is presenting in front. So it's a chronic cough. It occurs in mid-afternoon and evening, and there are no other symptoms. It's just dry cough, right? And it worsens in the cold weather, and everything else is abnormal or normal. So this is a classic case of it's a classic case of cough variant asthma. And you can diagnose this by spirometry or methicillin challenge. So methicillin challenge, I assume you guys already know what that is. It's basically when you give methicillin and the bronchoconstriction is increased, and person with asthma who is susceptible to bronchoconstriction will develop a more serious reaction, whereas the normal person will not. And spirometry showing reversible airflow obstruction, uh, it means that during the episode, the spirometry will show an obstructive pattern, but after the episode is completed, it is going to be normal. So that's what this means. So these are two ways to diagnose asthma or cough variant asthma. Primarily, spirometry is used to diagnose asthma. Why are the other options wrong? Because cocaine use, it causes acute sympathetic symptoms such as chest pain, tachycardia, and not just chronic cough. Granulomatosis with polyangiitis is a multi-system disease with sinusitis, hematuria, hemoptysis, and there would also be abnormal imaging, so this cannot be at all. Sarcoidosis, it typically shows bilateral hilar lymphadenopathy on chest X-ray. So chest X-ray in this case is normal, so this cannot be the cause as well. Tuberculosis is chronic cough, but it has B symptoms such as fever, night sweats, weight loss, and also has abnormal imaging. Vocal cord polyp, it causes hoarseness and not just isolated cough pattern. So it's very important that with the case you must also know why the other options are wrong. That's also quite important because any one of these could be presented in as a question to you. So you must know that in which situations will these conditions be the right answer. So the objective is that chronic cough with normal chest imaging and no systematic symptoms, especially if triggered by cold or worse in the evening, is most consistent with cough variant asthma. Okay. So on mini mental status examination, he reports feeling okay, appears mildly irritated but cooperative, and has a mini mental state examination score of 22 by 30. And I have written it two times here. An 82-year-old man with a history of hypertension and hypercholesterolemia is brought by his daughter due to a 6-month history of progressive memory impairment and abnormal behavior, including episodes of wandering naked during the day and getting lost while driving, leading to removal of his driving privileges. He lives alone and has a remote history of head trauma at age 14. Family history is notable for Alzheimer type dementia in his paternal grandmother. His medications include simvastatin and diltiazem. Vital signs are normal and physical examination shows a slow but normal gait. Okay, so you have a man who has hypercholesterolemia, hypertension, and his mini mental status exam is less as well. So, what could be the cause? Take a minute to figure out what the answer should be. Okay, so the correct answer is add donepezil to the current regimen. The reason being that the presentation is consistent with Alzheimer's disease, moderate stage, because you can see that he is having progressive memory loss and impaired daily functioning. You can see that he has progressive memory impairment and just getting lost while driving and all of these symptoms. Behavioral changes are also there, which means disinhibition and wandering. This is talking about the part where he's wandering naked during the day. This is this is disinhibition and wandering. And MMSE of 22 is mild to moderate cognitive impairment. So if it's less than 22 or 22, it means that the patient is having mild moderate cognitive impairment. Initial pharmacotherapy includes acetylcholinesterase inhibitors such as donepezil, rivastigmine, galantamine, and mechanism of these is that they increase acetylcholine in the synaptic cleft, which leads to modest cognitive benefit. So these are acetylcholinesterase inhibitors. So they inhibit acetylcholinesterase, which is an enzyme that is responsible to clear out acetylcholine. So if you inhibit the inhibitor, the enzyme is going to increase, or the precursor, which the enzyme is responsible for clearing, will increase. Why the other options are wrong? Because diltiazem has no evidence of adverse cognitive effects causing dementia. It's a calcium channel blocker. Simvastatins are not associated with progressive dementia. Again, statins are safe. Clopidogrel is used for vascular disease and has no evidence of vascular dementia. So the patient is not undergoing vascular dementia. It's just undergoing normal Alzheimer's disease. So there's no point of adding clopidogrel. Selegiline is used in Parkinson's disease, and sertraline is used in major depressive disorder. So none of these medicines match what you're getting in the case. Education objective. So in elderly patients with progressive cognitive decline and functional impairment, initiate acetylcholinesterase inhibitors for Alzheimer's disease to slow symptom progression. Okay, quite an easy case. Question 8. Neurovascular status is intact and she's able to bear weight while walking, although she has been using crutches. So what is happening is that there is a 23-year-old woman with no past medical history presents with moderate right ankle pain and swelling 1 day after twisting it. Vital signs are normal. Examination shows edema over the lateral ankle, ecchymosis below the lateral malleolus, and tenderness over the anterior aspect of the lateral malleolus, while the posterior aspects of both malleoli are non-tender and neurovascular status is intact. Okay. And she's able to bear weight. So take a minute to figure this out. Okay. So the correct answer is use of a protective brace and early range of motion exercises. Why? Because this is a lateral ankle sprain. Okay, so the primary problem in this kind of question is you need to differentiate between a sprain and a fracture, which I'm going to tell you in just a bit. So X-ray is only going to be applicable if we are suspecting a fracture, right? So only applicable if we are suspecting a fracture. So this is a symbol for fracture. So which is that there would be an inability to bear weight, or there's going to be tenderness at the posterior tip of the malleoli. So this patient can bear weight and has no posterior malleolar tenderness, so there is no imaging needed. So I've made it simple for you guys. Ottawa rules are a bit complicated. Just two things you need to keep in mind is that either the patient is unable to bear weight, or she has tenderness at the posterior edge or the tip of malleola, right? And we could see the question that she's able to bear weight while walking, and the posterior aspects of both the malleola and non-tender. So then we don't need imaging. What we need is uh, uh, is management of the sprain. So which is the RICE therapy, the rest ice compression and elevation therapy. And also along with this, we do early mobilization and functional support. So we tell the patient to start walking earlier and not to sit around complaining of pain. This is going to lead to a faster recovery rather than immobilization. In fracture, however, we do immobilize the patient for a bit. So obviously, X-ray options will not be needed, and sprinting and referral is also not needed because this is not a cancer. So use Ottawa rules to avoid unnecessary imaging. Treat uncomplicated ankle sprains with early mobilization and functional bracing, or RICE therapy if it is available in the answers. Okay. So question 9. Question 9. Platelet count of 280, bleeding time of 6 minutes. We'll just read it from the beginning. So 27-year-old pregnant woman, G2P1 at 26 weeks gestation, presents for a routine prenatal visit. She is asymptomatic with normal vital signs, including blood pressure of 120 by 70. Physical examination is notable for ecchymosis in different stages of healing over the forearms and lower abdomen. Fundal height is appropriate at 27 centimeters. The uterus is non-tender and firm. The cervix is long and closed, and the fetal heart tones are normal. Hemoglobin is 12, platelet to 80,000, and bleeding time of 6 minutes. Which one is the answer? Take your time. And we'll move forward. So the answer is domestic abuse. It was quite simple. There is domestic abuse in pregnancy. What are the clues? So the clues are that there are ecchymosis in different stages of healing. First of all, this is the biggest clue. Then the presence of normal examination. There is nothing wrong with her examination. Bleeding time, platelets, everything is normal. So why are there ecchymosis if the bleeding time or the platelets and everything is normal? So why is there ecchymosis? So bruises in various stages of healing, and unexplained injuries. Uh, why are there injuries? These are the biggest clues to domestic abuse. And domestic abuse cases do pop up in the paper, so you need to keep that in mind. The labs are normal, and there are no obstetric complications or coagulopathy, which is noted. And because domestic abuse is very high risk, uh, considered high risk during pregnancies, so it just requires screening and intervention. Why the other options are wrong? HELP syndrome has deranged labs, and this patient has normal labs. So HELP syndrome has hemolysis and increased LFTs and decreased platelets. Very high yield disorder. ITP is thrombocytopenia. Here the platelet count is normal, so this cannot be the case. Preeclampsia is hypertension plus proteinuria. The BP is normal in this patient. And one Willebrand disease is a bleeding disorder. So there is no bleeding history or anything that points towards a bleeding disorder. So this cannot be the case. Education objective is that in pregnancy, bruises in multiple stages of healing with normal labs strongly indicate domestic abuse and not a hematologic disorder. Question 10. An 82-year-old woman presents with a 6-month history of insomnia, spending nights watching television or listening to the radio along with daytime fatigue and frequent naps. She has had a 5.4 kg weight loss over the past 6 months. Her husband died 3 years ago and her pet dog died 3 months ago. She appears disheveled with cracked lips. Vital signs show temperature 37.5 degrees, pulse 86, respirations 10, blood pressure 150 by 84, physical examination otherwise normal. On mental status examination, she has poor eye contact, delayed responses, word finding difficulty, and vague recall of recent activities. She takes 5 minutes to draw a clock and requires prompting to complete the task correctly and recalls 2 out of 3 objects after 5 minutes. Quite detailed case. I will give you some time to figure it out. Okay. So the correct answer is begin sertraline therapy. The presentation is consistent with major depressive disorder in the elderly, which is also known as pseudodementia, because this is a cause of irreversible dementia. So the key features are insomnia, weight loss, poor self-care, delayed responses, and cognitive impairment. But cognitive impairment which improves with treatment. So this is the biggest sign. Depression can mimic dementia, but patients show effortful, slow responses, often aware of the deficits. In patients with dementia, they're not aware of the deficits. Treatment is sertraline, SSRIs first line, and cognitive symptoms improve after more treatment. Now, why isn't sleep hygiene the right answer? Because depression is present. She's not just having problems with her sleep. If sleep was the only problem, then we would go for sleep hygiene. Grief counseling timeline and severity suggest major depression, not normal grief. So she's having her husband has died 3 years ago. So normal grief is about lasts for around 1 year. So this cannot be it. And also, the symptoms are not just of grief; they are pointing towards depression. New pet, not appropriate medical treatment. That's not scientific or evidence based. Donepezil is for Alzheimer's disease. So this is depression related cognitive impairment. So we solved the question related to Alzheimer's in the same paper, and now we are solving a question related to depression in this. So now you can understand that these are two conditions that can present together and might look like same, but they're not same. Education objective being that elderly patients with cognitive impairment plus depressive symptoms likely have pseudodementia treated with SSRIs, not dementia medications. Question 11. 16-year-old girl is brought by her parents due to 5 months of progressive social withdrawal, decreased academic performance, fatigue, hypersomnia with 10 to 12 hours of sleep nightly plus daytime naps, decreased appetite with 5.4 kg weight loss and loss of interest in activities she previously enjoyed. She denies intentional dieting and is unconcerned about weight loss but reports nausea after eating and becomes tearful when discussing her symptoms. She denies feeling depressed. She is sexually active with one partner and usually uses condoms with regular menses and last menstrual period 1 week ago. She denies drug use and has minimal alcohol exposure. Vital signs are normal and physical examination shows a tired appearance without lymphadenopathy or abdominal abnormalities. Lab studies show hematocrit 39% and leukocyte count 7,000. What could be the answer? You guys also need to focus on the age of the patient and the symptoms. Right. So the answer is assessment of suicide risk. Again, this is important for teenagers. I'll tell you guys why. So the question is for major depressive disorder. It has the five SIGI caps symptoms such as anhedonia. So she quit the swim team. There is social withdrawal. There is fatigue. There is hypersomnia. She's sleeping a lot. There is weight loss and decreased appetite, and academic performance has also declined. There is tearfulness despite denial of depression. So teens commonly do deny depression, but there is tearfulness during a normal conversation, which is a very big sign. The next step is to always assess suicide risk. Teens are especially vulnerable to suicide. Every depressive patient is, but teens are especially vulnerable to suicide. So you need to assess the suicide risk first before offering any further workup or treatment. Why the other options are wrong? Because there are no signs of an ABV disorder. There is no sign of any thyroid disorder, and she is sexually active, but there are psychiatric symptoms, and the question is not pointing towards any pregnancy sign, or the question is not giving you any hint to go for this. And endoscopy is not needed because there are no GI red flags, no bleeding, no severe pain, no anemia. So point B that adolescents with suspected major depressive disorder, the first step is suicide risk assessment. Okay, so I guess that was clear enough. Question 12. Lab evaluation reveals an erythrocyte sedimentation rate of 70. This is ESR, and obviously this is increased. You need to know the normal values of these lab characteristics. 77-year-old man presents with a 4 week history of aching and morning stiffness in the shoulders and hips, causing difficulty getting out of bed and reaching overhead. He reports low-grade fever and generalized fatigue. On examination, there is decreased range of motion of the shoulders and hips without joint or muscle tenderness. Okay, so this is a very common uh, case presentation. Read the answers. Tell me what you think. Concentrate on the ESR, the age, the aching of shoulders and hips, and low-grade fever. The correct answer is prednisone therapy because he is suffering from polymyalgia rheumatica. Again, it's in the age more than 50, peaks in the 70s. Clinical features include bilateral shoulder and hip girdle aching. Morning stiffness is more than 45 minutes. So there is no true muscle weakness. What this means is that if you are going to examine the patient, the examination is going to be normal, right? So there is decreased range of motion of the shoulders and hips without joint or muscle tenderness. So there is no true weakness. There's just decreased range of motion, right? They're not saying that the muscle is weak. They're not saying that the muscle strength is 2/5 or 1/5 or 3/5. That's not what they're saying. So The patient, although may feel that his strength is decreasing, but his strength is not decreasing. So there is no true muscle weakness. There is markedly elevated ESR. There is low grade fever. First line treatment is low dose glucocorticoids. They bring rapid symptom relief, and you need to monitor for giant cell arthritis. So in giant cell arthritis, you give high dose steroids. In polymyalgia rheumatica, you give low dose glucocorticoids, low dose steroids, basically. Why the other options are wrong? Uh, Basically, you need to know why, in which cases these are used. So allopurinol is used in gout. Amitriptyline is used in chronic pain syndromes. Colchicine in gout again. Cyclophosphamide is an immunosuppressant for vasculitis. Ibuprofen is an NSAID. It's for pain relief, so it's not sufficient. Methotrexate is not initial therapy, and it's a DMARD, so it's not really used in PMR. And plasmapheresis is reserved for autoimmune diseases. So this is the indications. These are the indications that you must know. Education objective: elderly patients with proximal aching, morning stiffness, and elevated ESR should be treated promptly with low dose prednisone. Okay, 56-year-old woman with well controlled type 2 diabetes presents for a routine examination in October. Vital signs and physical examination are normal. She states that she does not want the influenza vaccine this year because she knows people who came down with the flu because of the shot. So, what should be your uh, recommendation? All right, so this is an ethics slash infectious question. The correct answer should be that patients who are incubating the influenza virus when they receive the vaccine mistakenly attribute their symptoms to the vaccine. So basically, you can get flu. That's not the problem, right? But this is how you should. This is how you should convey that message. So you need to counsel for the influenza vaccine. There's a common misconception that vaccine causes influenza. That's not the case. Inactivated influenza vaccine cannot cause flu. Misattribution occurs if the patient is already incubating virus or has mild side effects. Then, if the patient already has a virus, then the vaccine cannot really do anything because it works on uh, preventing the viral infection. Effective counseling includes explaining the mechanism of action, addressing misconceptions, and emphasizing high risk populations of diabetes. So she is diabetic, right? So that's why we're telling them that you should get the vaccine. Why other options are wrong? The first option is just saying that trust me. So it is an authoritarian approach. Second option is if you're not going to accept the vaccine, I'd like to sign a waiver. So this basically you're just again you are transferring your responsibility, which you should not do. So it's a legalistic approach. Does not address the misconception. And in C, you are just saying that basically influenza is dangerous, so that's why you should get the vaccine. That's a fear-based approach, and that is never right. And in E, you're basically being very negative and confrontational. So that's not something that you should do with the patient. So provide clear, factual, non-judgmental explanations and address their misconception and the myths that they have in their mind. So 82-year-old woman presents with a 6-month history of frequent falls. She experiences a sensation of imbalance while walking or turning but has never lost consciousness. Her medical history includes stable coronary artery disease for 5 years and osteoarthritis of the knees for 10 years. She takes aspirin. She lives in an assisted living facility. Pulse is 80, respiration 14, uh, 140 by 85. Blood pressure examination. She has difficulty raising from the chair and gait is slow and she's unstable. Muscle strength is 4 by 5. So you can pause the video and see what the answer is. Physical therapy. So the best way to prevent falls in older adults is to do physical therapy. Common causes are muscle weakness, balance deficits, lower extremity osteoarthritis. The first line management is targeted physical therapy, focusing on strength training, balance exercise, and gait training. These three should be included in the physical therapy that you are recommending. And why are the other options wrong? So, wheelchair does not uh, provide treatment for this condition. It's basically making the patient dependent. Ambulatory ECG, there is no point because there is no cardiac problem. Carotid duplex, there are no focal neurological deficits present, and meclizine is a vestibular suppressant. So patient does not have vertigo. So recurrent non-syncopal falls, lower extremity weakness and gait instability point towards uh, muscle weakness or balance problem, and you should always initiate physical therapy to improve strength and balance. Last question. Cardiac auscultation reveals an opening systolic click over the left fourth intercostal space. 32-year-old woman. She has a sudden onset sweating, shortness of breath, chest discomfort. 30 minutes ago, she's experienced this symptom again, and she's worrying that she's going crazy. And everything else is quite normal, except for the blood pressure, it's a bit high. What could be the cause? So, I think this one's quite easy. This is mitral valve prolapse because just remember that palpitations, anxiety-like symptoms, and chest discomfort in young women with a systolic click is pointing towards mitral valve prolapse, unless proven otherwise. So there could be a chest discomfort as well in these episodes. Tachycardia would always be there, and this is not generalized anxiety disorder because this is not psychiatric problem. There are no thyroid symptoms present, and this could not also be panic disorder because although they are quite simple but similar, but systolic click point towards the MEB. And paroxysmal atrial tachycardia is quite rare, so this could not be the cause. I guess this one is clear now.